This is the introduction to hormones and pituitary function. The pituitary gland is referred to as the master gland. It secretes hormones that regulate other glands within the body. It is needed for metabolism, gonadal function, thyroidal function, and adrenal function. It is a transponder that translates neural input into a hormonal or endocrinologic product. The different functions of the pituitary include feedback loops, which we'll talk about in a minute, pulsatile secretions to release a chemical element to the rest of the body for communication, diurnal rhythms, which means there may be a variation between the morning and the evening levels, and there can be environmental or external modification of its performance depending on the environment that you're in. The first thing I'd like to talk about is a simple feedback loop. This is really important to understand moving forward in your clinical chemistry education. There are many times where you're going to have to answer a question in a case study or something like this, and it's really hard to memorize what disease is present just knowing if the TSH or TRH levels are increased or decreased. Understanding this loop that you see in front of you right now is going to be crucial to be able to answer those case study type questions that you're not just going to have in clinical chemistry, but you're going to see out in the laboratory environment, you're going to see again in capstone, and you also may come across these on your boards. So let's take a quick peek at this. The first thing that you have is the hypothalamus, which is located in the brain with the pituitary. This is an example of how this works with the thyroid. Now there's a feedback loop for other organs as well, but in this scenario, we're just going to use the thyroid as an example. Okay, so the first thing that happens is the hypothalamus is going to send something called thyrotropin releasing hormone. The thyrotropin releasing hormone that's released from the hypothalamus will then tell the pituitary to release something called thyroxine stimulating hormone or thyroid stimulating hormone. So this thyroid stimulating hormone is then going to tell the thyroid to release thyroxine that you see over here into the bloodstream. Thyroxine is the main thyroid hormone that has a control over heat regulation, heart contractility, rate of heart rate, and metabolism. So if there is enough thyroxine in the bloodstream or too much, it will then go and tell the hypothalamus, okay, there's enough. The hypothalamus will then slow down the amount of TRH. It will slow down the amount of TSH, which will hence tell the thyroid to slow down the amount of thyroxine. Okay? On the other hand, if you don't have enough thyroxine in the bloodstream, let's say that you need more because of more energy demand, think of a runner or something like that, the thyroxine level in the bloodstream would be low. The hypothalamus would be able to pick up the fact that the thyroxine levels are low. It will increase the amount of thyrotropin releasing hormone, which will tell the pituitary to increase the amount of TSH, which will then tell the thyroid to increase the amount of thyroxine. So this is how the feedback loop works. Okay, this will apply to the other hypothalamus pituitary hormones that we will be learning about as well. All right, let's look at each of the hypothalamic hormones first. Most of these hormones are peptides and bioactive amines that are common products of the hypothalamus. So there's multiple actions that these hypothalamic hormones have, and as you can see on the side, it is very important to be familiar with these and what they do. So these hypothalamic hormones have multiple actions. The first one, thyrotropin releasing hormone, stimulates the secretion of TSH and prolactin from the anterior pituitary. Gonadotropin releasing hormone stimulates both luteinizing hormone and follicle stimulating hormone from the anterior pituitary. Somatostatin actually stops growth hormone and TSH release from the anterior pituitary. I always tell people when you hear somatostatin, you think statin, think stop. Statin stops the release of those. CRH is corticotropin releasing hormone. That releases adrenal corticotropic hormone from the pituitary. And then we have a growth hormone releasing hormone. And this releases growth hormone from the anterior pituitary. So as you can see, a lot of them have releasing hormone in them. If you hear releasing hormone, think hypothalamus. And a lot of those hypophysiotropic hormones are found throughout the central nervous system, gut, pancreas, and other endocrine glands. So we find them all over the place. So moving on from the hypothalamus, the next step that we talked about was the pituitary. There are two parts of the pituitary, the anterior pituitary and the posterior pituitary. First, we're going to talk about the anterior pituitary. This guy is larger and more complex than the hypothalamus. He has another name called the adenohypophysis. So you'll hear this referred to as both the anterior pituitary and the adenohypophysis. So there's a couple different types. We have tropic and direct effectors. The tropic hormone acts on another endocrine gland. An example of that would be growth hormone. The direct effectors act directly on a peripheral tissue. So in order to memorize which ones come from the anterior pituitary, try and remember flat pig. And if you wonder how to put anterior with the flat pig, what I think about is a flat pig laying in the mud and having ants crawling on him because ants like dirt. Okay, so the anterior pituitary and flat pig. FSH, LH, the A is ACTH, T, TSH, P, prolactin, ignore the I, and G being growth hormone. So flat pig are the hormones that are there. So if that'll help you kind of memorize which ones are anterior versus posterior, I really hope it does. So let's talk about each of these hormones and what they do. First one is growth hormone. We'll talk about him in more detail here in a little bit, but he affects metabolism and stimulates the liver to produce other growth factors. We'll go into detail with him in a little bit. The next one is luteinizing hormone, LH. He is in charge of ovulation and testosterone production from the Leydig cells in the testes. FSH, or follicle stimulating hormone, he helps produce eggs in the ovary, which is called folliculogenesis, also spermatogenesis in the male, the production of sperm. TSH, which we talked about a little bit in the last slide, thyroid stimulating hormone. He directs thyroid hormone production from the thyroid. And the last one, adrenal corticotropic hormone. He regulates adrenal steroidogenesis. So, for example, Cushing's disease is something we'll learn about in the next couple of weeks to talk about what all those adrenal hormones do. All right, here's where we're going to go into a little bit more detail. First one is growth hormone and what it does. We'll talk about why I have Abraham Lincoln up here in the right-hand corner in a minute. It's considered amphibolic, which influences anabolic and catabolic processes. It allows your body to effectively transition from being fed to fasting without a shortage of substrates. Okay, so if you ate and then you went and ran, and then you ran out of energy, it allows you to move into other types of energy sources rather than just collapsing right there on the sidewalk. It directly antagonizes the effect of insulin and glucose metabolism, so you're allowed to control that with growth hormone. It provides hepatic gluconeogenesis, which is a production of new glucose from non-carbohydrate sources. Remember, you guys all love those words in Chemistry 1. It stimulates lipolysis, so taking fat and breaking it down. It would be very difficult to lose weight with a lack of growth hormone. It enhances protein synthesis and stimulates the production of insulin-like growth factors. So it does quite a bit, very important. Now, this is where Abraham Lincoln comes into play. We talk about acromegaly. That is an excess amount of growth hormone, usually from a pituitary tumor. It can cause gigantism, bony and soft tissue overgrowth, progressive enlargement of hands, feet, mandible, and skull. If you ever see pictures of Abraham Lincoln, he was very large, had very large hands. But unfortunately, we do see arthritis, diabetes, hypertension, atherosclerosis, muscle weakness, difficulty sleeping or sleep apnea, losing, not being able to breathe at night, and a shortened life expectancy. I think a lot of men end up with enlarged hearts and things like that, which I believe Abraham Lincoln did have some of those issues. On the other hand, we can have a growth hormone deficiency, and that would cause just the opposite. It would cause somebody to be smaller and not grow normally. Usually it can be genetic or due to tumors. In adults, you could have a dysfunctional pituitary. The genetic defects that usually happen is you have a mutation in the growth hormone releasing hormone gene or a failure of growth hormone secretion. You could have a loss of the gene completely. You could have a growth hormone insensitivity where you just don't react to it. Or you could have lesions on your pituitary or hypothalamus. There's a number of things. And I think they can do a growth hormone replacement in these people. The next one is prolactin. Prolactin is just as it sounds, which makes it kind of an easy one to memorize. Its physiologic effect is lactation, as you can see that I have in the middle. It's secreted by the anterior pituitary after stimulation by the thyrotropin releasing hormone. It is actually related to growth hormone and human placental lactogen. Sometimes you'll hear about human placental lactogen. That also is involved in lactation. It's considered a stress hormone. It has vital functions in reproduction, especially the lactation. It's a direct effector on the mammary glands, and it's inhibited by dopamine. Okay, so you need to know that as well. When somebody does have excess prolactin, it usually leads to hypogonadism, which is just as it sounds. Shrinkage of the gonads, or sometimes they can even, in children, become very difficult to figure out whether they are male or female. The next thing here is a prolactinoma. A prolactinoma is a pituitary tumor that directly secretes prolactin, too much of it. Clinical presentation depends on the age and the tumor size. Usually with premenopausal women, we'll find menstrual irregularities, amenorrhea, infertility, and galactorrhea is a leaking milk when you're not supposed to be. Men and postmenopausal women, we can find headaches or visual complaints. And then this last term, this is the idiopathic galactorrhea. This is lactation in women with normal prolactin levels. We don't know why it's happening, it just happens. Not very often, I don't think, but it can happen. Next, we're going to talk about the other part of the pituitary, the posterior pituitary. It's an extension of the forebrain and represents a storage region for oxytocin and vasopressin. Oxytocin plays a critical role in lactation, and it also plays a major role in labor and parturition. I think everybody's heard of somebody who's been in labor where the labor is not progressing or they're induced and they gave them Pitocin in an IV. Pitocin is a synthetic form of oxytocin, and it causes the uterus to contract. It's also been shown to have effects on pituitary, renal, cardiac, and immune functions. But major role is labor, parturition, a little bit of lactation. All right, the next one is vasopressin. This is also known as antidiuretic hormone. The hypothalamus actually does release a little bit of this as well, but the posterior pituitary is a major player in this. Its major action is to regulate renal free water excretion and water balance. It's a potent pressor agent and affects blood clotting as well. And the big thing with this is people that tend to have a deficiency of antidiuretic hormone for some reason end up with diabetes insipidus. So what happens is they drink water, they drink water, they drink water. They don't have the antidiuretic hormone to be able to tell their kidneys to hang on to it. So what they do is they just continuously urinate out the water that they're drinking. Hence the polyuria, excess urine. So then they become very, very thirsty. So this intense thirst, which is called polydipsia, causes them to drink more and more, but they just keep peeing more and more. So even though they could be drinking a couple gallons of water a day, they still dehydrate. So this is something that would need to be corrected through the use of artificial antidiuretic hormone. Okay, pituitary tumors can happen sometimes. And this is kind of interesting. According to autopsy studies, up to 20% of people have clinically silent pituitary adenomas. So 1 in 5 of us are walking around with a pituitary tumor. Findings consistent with pituitary tumors are observed in 10 to 30% of normal people undergoing MRI exams. So, 1 to 3 out of 10 of us will have an MRI and they'll find one. It can also account for 91% of lesions from patients who have undergone transsphenoidal surgery. I think what that means is going up through the throat or the nose to get to the pituitary to fix these situations. Also, we find that when somebody is going through puberty or pregnant, that the pituitary gland is actually enlarged. All right, the last thing I want to talk about with the pituitary and the hypothalamus is the type of hormone testing that we do. So all of these hormones that we just talked about, FSH, LH, TSH, the main type of testing that we do is immunoassay. Immunoassay is very efficient at picking up hormones that are in such a small quantity, they're difficult to detect. It would be too hard to use a spectrophotometer with colorimetric methods because the color would not be dark enough because there's not enough there. With immunoassay, we apply a tag or an antibody with a tag, and if that antigen or hormone is there, it will bind with the antibody and will create a light or a darker color. So this is just a way of picking up what I call a drop of water in a swimming pool. It's easier to detect. Okay, this concludes the portion on the hypothalamus, anterior, and posterior pituitary.